Well, as Brad mentioned, my name is Shawn Jones-Jopes. I'm a general pediatrician here in Lincoln. I've been here since about 2004, and I'm also president of Complete Children's Health. We're a larger pediatric practice here in Lincoln, take care of about a little over 20,000 patients in the Lincoln and surrounding area. So it's a lot of peds patients. We have a lot of kids in that 5 to 11-year-old age group that we take care of. So it's been a pretty exciting couple weeks. I will say this is sort of rapid fire information that we're getting over the last several weeks with the vaccine. And so if you do end up having any questions that I'm not able to answer, I'm happy to find the answers and get back to you. So please don't hesitate to ask anything you have. If I don't know the answer, I'm sure I can find someone who does. So I'll start out by talking about the events of the last couple of weeks. As you probably already know, on the 26th, the FDA Advisory Committee that looks at vaccinations and makes recommendations to the FDA as far as authorizing them met, and they did vote to recommend that the FDA authorize use of the COVID-19 Pfizer-BioNTech vaccination in the 5 to 11-year-old age group. The FDA followed up, I believe it was on Friday, the 29th, and they actually did give that EUA. And so that was the first step. And then the second or third step, I guess, happened yesterday when the ACIP met. The ACIP is an advisory committee made up of scientists and physicians who are experts in vaccination and immunology. And they met to make a recommendation based on the information presented to them from the FDA and from Pfizer, whether or not this vaccine should be used and who it should be used for. And they voted unanimously that this vaccine should be offered to all 5 to 11-year-olds in the United States. And it was a very strong recommendation. They had a long meeting, lots of questions, lots of information presented, and they all unanimously made statements, not just voting in favor, but making statements how strongly they were in favor. So that's good news. These are smart people. They know how to analyze this data. They ask a lot of really hard questions. They're not afraid to push back, as they did with the booster discussion a few weeks ago when that was being discussed, when there isn't enough data, and they felt very confident with their decision. So that's good news for us as pediatricians, and it's good news for us as a community that we can protect this younger age group with vaccination. So I'm going to talk a little bit about the who, what, when, and where of this vaccine. So the who I already mentioned, it's being offered to children 5 to 11 years of age, regardless of risk factor. And that's important because we weren't sure based on the data, how the data would turn out. Is this something that maybe is better just to give to high-risk kids, or maybe children who are living in high-risk households, or is the data good enough that we should give it to everyone? And they did recommend that we give it to all children, regardless of risk factors. The what, it's the Pfizer-BioNTech vaccine. That's an mRNA vaccine. It's the same vaccine, but a different dose that's being given to patients 12 and up already. Currently, patients 12 and up are receiving 30 micrograms of that vaccine. And the pediatric dose, they did do dosing studies ahead of time to figure out how much vaccine would work for them. And that was part of that phase 1 trial. And the pediatric vaccine will be 1/3 or 10 micrograms. Because of that, they're shipping it and distributing it in a different vial. And so the current vial we're using happens to have a purple cap. The vial that we will be using in the pediatric population will have an orange cap, and the dilution is slightly different. It would be really hard to give 0.1 ml of the current vaccine that we're using, and so they're diluting it slightly different. It's going to be 0.2 ml for the younger kids, so probably a little more detail than you needed to know. But it is important because that affects the when of vaccinating, and so I'll get to that next. The when of vaccinating will be when we get vaccine. I did check with the health department before I came on today, and they're not ready to announce whether or not they have vaccine in stock yet. but they do have to ship different vials. So we can't just drop vaccine from the vials that we already have. So I would encourage you, I know there's been some states where governors have gotten on TV and said, call your pediatrician if you want your vaccine. And I would encourage you to hang tight as soon as we get vaccine and as soon as the health department has vaccine. I know that they'll be making announcements on the internet, on websites, on Facebook pages to let you know how to sign up for your vaccine. So try not to have everybody call their primary care office today, because it's probably more calls than we can manage. So and then the where, the vaccine will be given in primary care offices. And so we have a great partnership with Lancaster County Health Department, as do all the other pediatric practices in town. I know we're planning on getting vaccine from them when they have vaccine available so that we can administer it to our patients. And then in addition to that, the health department does have vaccine clinics planned. I believe they have their first one planned for this Saturday. And they're going to use school locations for that, high schools specifically. And so I know that they'll be announcing more information about that as they have vaccine and as they have information. It'll be given at pharmacies. So there are several pharmacies that have the federal contract. And so those pharmacies will also have vaccine that they'll be able to give to children. And I know Brad mentioned to me earlier that the Bryan Health Connect clinics are going to be offering that to their patients. So your primary care office, mass vaccination clinics, pharmacies are going to be in your main places, your federally qualified health clinics as well. And so there'll be lots of places where you can get your vaccine. I will say that the part of the analysis that the ACIP does, they look at who's interested and where they want to get the vaccine. It's a part of their feasibility analysis. And when they surveyed parents where they would feel most comfortable getting their vaccine, about 65% of caregivers said they would feel most comfortable doing it in their pediatrician's or family medicine doctor's office. And so that is the plan. That's why there's been a big push to make sure that primary care offices have the vaccine. So as soon as we have it, we will let people know. It's a lot of kids that will qualify for this vaccine. There's about 28 million kids in that 5 to 11-year-old age group, and at least 9 million kids represented by families that said, we're going to get it right away as soon as it's available. So we definitely want to meet that need. I wanted to talk a little bit about some background in regards to why this vaccine is important for kids 5 to 11. I know that you might hear, well, kids don't get COVID and COVID isn't a big deal for kids. And the reality is, one of the things that the ACIP looked at yesterday was whether or not that was true. What's the real impact of COVID-19 on the pediatric population 5 to 11? And we know that there have been over 1.9 million cases of COVID-19 in the 5 to 11-year-old age group. And that's actually identified cases. That's kids who had enough symptoms and enough disease that they went in and they got tested. There's a lot of kids who have COVID-19 who have mild symptoms that maybe never went to get tested or maybe didn't have symptoms at all. So that's an underestimation of how many kids have been exposed to COVID-19. There's been over 8,300 hospitalizations in the United States in this age group. And this is the age group that actually has the lowest rate of hospitalization out of kids. And so, but they still had 8,300 hospitalizations over the course of this pandemic. There's been over 2,300 cases of MIS-C. MIS-C stands for multi-system inflammatory syndrome in children. And it's a scary disease. It's a scary syndrome. Basically, these kids come in with a couple days of fever, somewhere around a couple weeks after their initial COVID infection. And the COVID infection that leads to MIS-C can be completely asymptomatic. So you may not even know that they had COVID-19. Sometimes we know that a family member had it, but they never had symptoms. Sometimes we don't know who they were exposed to, and we only know from antibody studies that they had COVID-19. They come in with a couple days of fever and nothing else. And as those of you who have had kids of your own or maybe practice pediatric medicine or take care of kids, you know, kids get fever sometimes with nothing else. And so when these kids come into the clinic, you don't know now, do they have early MIS-C and they're going to get really sick really fast and end up needing to go to the ICU? Or is this just some other virus? And that leads to a lot of unnecessary blood draws, unnecessary labs, just making sure that these kids are safe to go home, because unfortunately these kids can look good one minute and they can be in the ICU the next minute because they're so ill. And so that's a significant impact on our pediatric population and our pediatric providers as well. There have been 94 deaths in the 5 to 11-year-old age group since the pandemic started. Those are kids. Those are kids 5 to 11. And so when people tell me that, well, not that many kids die of COVID, those are 94 children that died of COVID that would be with us today if it wasn't for COVID-19. And so I'm really excited about having a vaccine to help us prevent those deaths and prevent those illnesses and hospitalizations. The other things that we look at when we look at whether or not to vaccinate kids are maybe not as severe as hospitalization or ICU admission or death, but they're still important. We do see secondary transmission in households and in schools. That's been shown over and over again in studies. And so those secondary transmissions affect families. They lead to lost job time, work time, they lead to lost salary, they lead to more stress on families, they lead to lost education time. And so that's significant. In addition, kids have been impacted by long COVID where they have chronic symptoms. Approximately 7 to 8% of kids in one study still had symptoms of COVID that were hanging on and affecting their lives at least 12 weeks after COVID-19 infection. Kids have lost school and work and socialization time. They've lost time at sports. They've had worsening of their mental and emotional health. We've seen widening education gaps, especially in some of the more affected communities, in socioeconomic groups. We've seen decreased physical activity in the office. We've seen increased body mass index, which affects their health long term. That's a part of my job as a pediatrician, is not just to keep kids healthy now, but to make sure that they're healthy for the rest of their lives by preventing illness now. It leads to decreased healthcare utilization. We've seen decrease in immunization rates because patients haven't been coming in for their well child care because they're nervous about getting sick from coming in the office. And we've seen an increase in adverse childhood experiences. And we know that these ACEs, as kids have more stress in the household, as they have more trauma in the household, they're more likely to have chronic health issues like diabetes and heart disease later on in life. One of those things that I'm also trying to prevent now as a pediatrician. One of probably the least talked about things in regards to the health and well-being of children is the loss of caregivers. By preventing illness in children and secondary transmission by preventing illness in children, we are helping to keep our whole community healthy. It's estimated that over 250,000 children have lost a caregiver during the pandemic. That's a lot of loss for these kids 5 to 11 to undertake. That's a big emotional toll for them. And if we can prevent illness in this age group, that's definitely something that we want to do. So I just want to put it in perspective how important this vaccine is and what a big jump this is for our patient population and for our community as a whole. I'll talk a little bit about the vaccine data and the FDA and the ACIP findings. Yesterday, they talked not just about the safety and efficacy information that they have from the phase 2 and 3 trials that were done by Pfizer and overseen by the FDA, but also the data that we have on the over 247 million doses of Pfizer vaccine that have already been given in the United States. That's a lot of vaccine and a lot of safety data. And we have a lot of really good safety data already on this vaccine in the populations that it's already been given to. And so they looked at that data on the 247 million doses, and then they also looked at that phase 2 and 3 trial. The phase 2-3 trial was done. It had a 2-to-1 ratio of patients who received the vaccine compared to placebo. Of course, it was blinded. And there were about a little over 3,000 patients in the vaccine arm and about 1,500 patients in the placebo arm. And when they looked at efficacy, it had about an almost 91% efficacy. So it prevented COVID-19 infection over the course of the study about 91% of the time. There were only 3 cases of COVID-19 in the vaccine group, and there were 16 cases in the placebo group. And of course, the placebo group was half the size of the vaccine group. So that's a very significant difference. One of the other things they looked at in regards to efficacy was something called immunobridging. They compared antibody levels that were developed, that were produced in the younger age group, that 5 to 11 study group, compared to the antibody levels that were in the 16 to 25-year-old age group. And they did that for a couple of reasons. One, it helps to also let you know, okay, then these antibody levels, if they're similar, it should have similar efficacy. And when you aren't seeing a huge number of cases, you want to check that as well. And when they did that, they did show immunobridging between the 5 to 11 group and the 16 to 25-year-old group. So overall, this vaccine was amazingly effective at preventing disease. One of the things that the ACIP and the CDC are experts at doing is modeling. And that was one of the things that I was really anxious to see tomorrow, because it's really great information when they do that. And when they look at modeling, they look at, if we were to vaccinate X number of patients, how much disease, how much morbidity or mortality would we prevent? And so when they did that, what they did was they looked at if 1 million doses of Pfizer vaccine were given to that 5 to 11-year-old age group, and those kids were followed for 6 months. How many cases, how much disease would we prevent? And what they studied with the modeling using the data as far as the recent incidence levels that we have had in September, it would prevent 114,000 cases, a little over 400 hospitalizations, 260 cases of MIS-C, and 130 ICU admissions. That's a lot of prevention over a 6-month time period. And that's why this vaccine is so important. The one other thing I didn't talk about, I meant to mention before, some people were wondering, well, why is it being given to all 5 to 11-year-olds? Can't we target kids who are at higher risk? And one of the other data pieces that I neglected to mention before was out of those hospitalizations, about a third, so about 32% actually, of kids who were hospitalized had 0 risk factors for COVID-19 severe infection. And so what that means is that kids without risk factors are still at risk of complications from COVID-19. And so if you only targeted those kids with more risk factors, you would miss a significant number of hospitalization prevention opportunities. And so you don't want to miss those opportunities. The other thing they looked at was safety and side effect profile, of course. We always look at that when we approve vaccines for use. The most common side effects seen in that 5 to 11-year-old age group were redness, swelling, and pain at the site of injection. It's not surprising, and we see that with most vaccines. It was a slightly higher rate in the 5 to 11-year-old age group than in the 16 to 25-year-old age group. And then systemic symptoms like fever, body aches, fatigue, those were seen in the 5 to 11-year-old age group, although interestingly at a lower rate than the 16 to 25-year-old age group. Although I can tell you as a pediatrician, that's not surprising. It's not unusual for me to see a family and the parents or the older kids in the family feel, horrible with their fever and their illness, and they're sitting back in the corner, and the 5 to 11-year-old has a fever but is bouncing off the walls. So that's not at all surprising that those systemic symptoms didn't seem to bother them as much. There were no safety concerns or serious adverse events related to the vaccine that were elicited during that study. And that's a big deal. One of the things we talk about with vaccine research is serious adverse events. And there were 4 serious adverse events in the vaccine group, but none were related to the vaccine. There were 2 broken bones. There was a swallowed penny. And then there was an infected joint that was unrelated to the vaccine. So those were the only severe adverse events that occurred to patients during the study, and none of them were related to the vaccine. There was no cases of anaphylaxis. There were no cases of myocarditis or pericarditis, and there were no cases of Bell's palsy, and there were no cases of appendicitis during the course of the study. So that's really a big deal, and it points to the safety of the vaccine. Safety monitoring does not end at the end of a phase 2-3 trial, excuse me. We will continue to follow the safety data, and there are several methods that the CDC uses to follow and the FDA uses to follow safety data. The two main ones are the VAERS system. The VAERS system is a passive system where patients and providers can report side effects and complications of vaccinations, and then those reports get investigated to see whether or not there's a link, and also to watch whether or not there's a pattern in regards to the types of side effects or complications. The other system is something that was new. It was started with the COVID vaccine. That's the vSafe system. I would highly encourage people, when you get your COVID vaccine, to sign up for vSafe. This is a really important part of ongoing monitoring, especially during this EUA process. vSafe is a system where you register, you let vSafe know that you received your vaccine, and then they send you messages that help you to log in and link to report whether or not you've had any side effects. So, I did vSafe when I had my vaccine, and you get a message every day for a few days, and then once a week, and then once a month. And they ask you questions like, have you had any fever, body aches? How are you feeling? Have you had any side effects? Have you had to miss work? When they look at long-term data, they also ask you, have you had COVID-19 in the last few weeks? And so that's how they monitor ongoing safety and efficacy. So really important. Parents will be able to sign up their kids for vSafe using their smartphones. Obviously, this is a 5 to 11-year-old age group, so it'll most likely be the parents answering these questions for the kids, but that will continue with the pediatric indication. So that's really the main things that I wanted to talk about today. I know that's a lot of information. There's a lot of information for me to learn over the last week and a half and over the last few months. And so I'm happy to answer any questions.
Thank you, Dr. Jones-Jobst. That was very informative, so we appreciate it. Media, yeah, feel free to submit your questions via chat, or if you'd like to unmute yourself and ask in person or via Zoom, that's fine as well. I did want to follow up quickly on a couple things. I just want to let you know, Dr. Jones-Jobst mentioned the clinics coming up. So Bryan Physician Network is working closely with the health department to host COVID-19 vaccine clinics at select Bryan Physician Network locations. However, these clinics will only be for Bryan Physician Network patients, and specifically ages 5 to 11. So, it's a closed vaccine clinic for patients only. However, we will be working with the health department to help facilitate that. I can also let you know that since the start of the pandemic, Bryan has treated 37 COVID-19 pediatric patients. And as of today, we do have one positive pediatric patient in our hospital. So as Dr. Jones-Jobst mentioned, we are seeing hospitalizations in our community, in our local community. So that kind of backs up some of the information that she shared as well. So any questions, please feel free to unmute, and then also to submit them via chat if you'd like. Okay.
Hard to believe I answered every question.
Right. Yeah. That's a great job. Did a very good job. Okay. Well, if there are any follow-up questions, media, please feel free to reach out to me. Here's a question, from Jack. Yeah. Is this still a 2-dose thing? Can you elaborate on that, please?
Yeah, that's a great question. Yeah. So it's just like the adult and 12 and up version. It's a 2-dose series given at least 3 weeks apart. And that's important because that second shot helps to elicit that memory antibody response, so that memory immunity response, I should say. And so that's an important aspect of the vaccine. Actually, interestingly, the side effect profile, most patients actually had less side effects after the second vaccine, which is different than what we saw with the older kids and adults. So Let's see, can kids expect to feel lousy after the second dose like some adults did? Yes, although that kind of goes to that systemic symptoms question that I was telling you about. The 5 to 11-year-old age group saw less of those fever, fatigue, myalgias, feeling pretty crummy after the vaccine than that 16 to 25-year-old age group. So it's possible, but it's less likely than it is for at least when they compared it to the 16 to 25-year-olds, which I believe had less of that than the older adults. So, but I'd have to look back at that comparison.
Okay, thank you. Anybody else have any other questions? Okay, here's a question, Dr. Jones-Jobst. As someone who deals with kids all the time, how big of a deal is this to be able to offer them the COVID-19 vaccine?
It's a big deal. You know, kids have been, in my opinion, of course I'm biased, I'm a pediatrician, but kids have been disproportionately affected by a lot of issues during the pandemic. And it's not unusual for us to forget about kids. You know, when the pandemic started and we went on lockdown, kids were stuck at home. And while many of us at least got out of the house to run errands and go to the grocery store, and I know there were lots of people going to Home Depot and doing some home improvement projects, these kids were at home. And they were struggling to learn from Zoom. Many kids, especially if they had high-risk patients or family members at home, had to stay home on Zoom all year last year in order to prevent infection, and maybe are still on Zoom now because of their own personal health issues or because of family members at home. I have a nephew in California who was home all of last school year. He's an only child. And he was all by himself, you know, trying to learn from Zoom. So when we approved the vaccine for the older age groups, and we told people initially when disease levels were low and this was appropriate, that you could be out and about without a mask on if you were vaccinated, that affected kids. You know, I have an 11-year-old at home and a 13-year-old at home. My 13-year-old is vaccinated. My 11-year-old is not. And I've told this story before. Some of you may have heard it. My 11-year-old said, you know, I've been wearing my mask for everyone else, and now no one is wearing their mask for me. And that's true. We were vaccinated, and we were, when disease levels were low, able to take our masks off, and kids weren't. We've been saying things like, if you're vaccinated, it's safe to travel. Well, how does that make a 10-year-old or a 9-year-old feel that they're second-class citizens? So this is a big deal for kids. This is going to open up opportunities for them to go back to more normal life and feel more like a part of the rest of society. And this is going to allow kids who have high-risk family members to go out and do more activities and be more open. I'm hopeful that eventually too, we'll be able to include some of those even younger kids if the safety and efficacy data shows that it's effective and safe to use.
Great. We did have one more come in, Dr. Jones-Jobst. How do you think the availability of vaccines for kids should affect the mask mandate in school? Should districts reevaluate now that the vaccine will be available? Kind of offer your thoughts or your opinions on that.
You know, we have multiple things that we do to prevent COVID-19 transmission. It's not an all or none. It's not, it's really a layered approach. And so what we've been doing is vaccinating those who can and are willing to be vaccinated. And I would encourage everybody who can be vaccinated to be vaccinated. That's our #1 preventive effort. But masking is another layer. So when you look at a layered approach to protecting people from transmission, you also have to look at what the likelihood of being exposed and the likelihood of infection is. And so it's important when you're doing that to look at what the incidence of illness is in your community. And so in regards to getting rid of mask mandates in school, we have to get disease burden down to be able to take those masks off. And that goes back to what I was saying before, where during the summertime, when we had low levels of disease in the community, it was appropriate to get rid of masks for those who were vaccinated. But until we have good vaccination levels and lower disease burden, we still need that layer of protection. There are other layers of protection too. There's ventilation, but it's, October in Nebraska, and we're due for a hard freeze. We're not going to open windows in classrooms. And so we're limited, and we're going to be inside more. So, and we have crowded schools. That's one of the reasons why LPS is building new school buildings. So we have to keep that in mind too, that it's hard to social distance, it's hard to ventilate, and we have high disease burden in the community. So, once again, we need data, we need information about how much disease we have in a community, and we need to get levels down and